screen. هل كده ابتدت السكرين عندكم؟
تمام يا احمد، تمام، باينه كده كل حاجه. كويس قوي.
Okay, so the first thing is we want to understand why do we want to use a dedicated decalcification device, if we may call it. Now, this is just to show you how frequently do we come across calcification. And we do know that it is slightly more common with males compared to females. But if you look at the age distribution, we do encounter coronary calcification not infrequently, and that is obviously quite progressive with age as well. We also understand that the risk factors for atherosclerosis are to a great extent similar to those leading to coronary calcification, being along the milieu of the process of atherosclerosis itself. But one thing I want to draw your attention to is the mere fact that the pattern of calcification is slightly different with different risk factors compared to others. So if you look at sort of classic coronary atherosclerosis risk factors, you'll find that those are mostly associated with intimal calcification. So advanced age, diabetes mellitus, dyslipidemia, hypertension, male gender, and cigarette smoking are predominantly involved or associated with intimal calcification. Now, advanced age and diabetes, you also get a degree of medial calcification. But when it comes to chronic kidney disease, you get a very heterogeneous picture. So along the entire spectrum of renal dysfunction, you get different degrees of both intimal and medial calcification, with hypercalcemia in particular related to medial calcification. And that will have strong implications about not only the pattern and the severity of obstructive coronary artery disease, but will also affect the modality of choice to get prostate. The second question is, so how does calcification really alter the prognosis? And this is interesting, relatively recent work from Mount Sinai. And contrary to, well, we do know that a 0 calcium score is associated with a very low risk of adverse coronary events within the ensuing 5 years. However, on the other extreme, a very high calcium score does not necessarily mean that you are at risk for acute coronary syndromes. And the reason perhaps is what we see on this chart on the left-hand side. And you can see that the pattern of calcification is perhaps what makes the difference. So if you have no coronary calcification whatsoever, your chances of getting acute coronary syndrome are quite low. However, if you do get this pattern of micro or speckled or fragmented calcification, this heterogeneity within the calcific plaque or the atherosclerotic plaque leads the way to plaque vulnerability and acute coronary syndromes. And as one progresses towards more advanced degrees of sheet-like or continuous calcification, this is a sign of plaque stability to a great extent. Then you become prone to more stable type ischemic heart diseases and heart failure or ischemic cardiomyopathy. And perhaps the only exception to that is what you get as the is prone to cause an acute coronary syndrome event. And on the right-hand side, that's just another way of depicting the distribution of the pattern of calcification or the density of calcification and the risk of acute coronary syndromes. So again, no calcification, the chances of plaque rupture are quite low. But as you get this pattern of heterogeneous calcification, the chances in the head here of suffering from an acute coronary syndrome are quite high, and then they continue to decline with more continuous sheets of calcium. Perhaps more importantly, or more to the point for this lecture, when it comes to intervention, we do know that the presence of calcium poses a big challenge for us. One, it inhibits circumferential expansion, and you can see this plot chart that the more the arc of calcium in terms of degrees extends, the less likely you're able to achieve sufficient stent expansion. And we do know that stent expansion is perhaps the most important factor related to stent failure on both the short and long terms. But besides expansion, we also know that deliverability is a big issue. So having calcific vessels per se poses some challenges. If this is also associated with a bit of tortuosity, we've all encountered how difficult this is to overcome in the catheter. In terms of endpoints, we also know that interventions to patients with heavily calcified vessels is associated with worse outcomes at 1 year. And this is from the Horizons AMI and Acuity studies. And you can see that patients with higher degrees of calcification tend to suffer more major adverse cardiovascular events. This was at 1 year on this occasion. So how does it really work? So the main mechanism is differential cutting. And by differential cutting, we mean the Burr's ability to ablate through stiff structures and spare elastic structures. And this is related to the stiffness and friction coefficient of the vessel. So the surface of the tissue needs to be able to generate sufficient stiffness to the burr. And you can notice that easily. If you get the burr and apply it to your finger, it will just jump off the finger without causing any ablation. This is in contrast to highly calcific or highly fibrotic plaques. The second thing is the concept of orthogonal displacement of friction. And this is essentially related to translating longitudinal resistance to transverse resistance that can be overcome by the rapid spinning of the burr. And we utilize this in CTOs, for instance, with microcatheters. When it's difficult to push them through, we rotate them. But we also use this in everyday life. And these are two examples of the same physical concept of trying to translate longitudinal resistance and overcoming it by transverse resistance, which can be overcome by rotation. Now, there are certain advantages that come with rotablation. A, they do not work in the same traumatic way that balloons work. So they minimize the wall stretch and elastic recoil because of the absence of barotrauma. They also are able to address all sorts of plaque morphologies. And you get the added advantage, besides ensuring good expansion of the stent, you also facilitate the delivery of the stent itself. And we do know that the particles or the micro debris resulting from the ablation procedure are well within the reticuloendothelial system of the heart to remove. So the system itself, this is the first generation of the rotablator, which has been around for almost 40 years now, and for 30 years, sorry. And this is not the RotaPro, the second generation, which is still not available in Egypt, although the latter still utilizes the very same concept. But if you look at the system, you'll have a console, a foot pedal that gives you control over the burr, over rotation or no rotation, the advancer, which is essentially the part that you manipulate during the procedure, the burr itself hung on a catheter, and this is the active component, what actually does the ablation, and what we call the backstage, was the tank regulators and the attachments and all the wires, and we'll get to that in a second. And if you look at the advancer itself, the advancer is broken into the RotaLink, the catheter itself, a connecting shaft between your button that you will move, advance, and retract, and a number of connectors which we'll come to in a second, and this is the body of the advancer itself. Now, if you look at every single component of those separately, we start off with the burr itself. Now, the burr comes latched onto a catheter. The catheter has an external plastic sheath, which is 4.3 French outer diameter, and that is similar for all burr sizes. Then there is a stainless steel coil that we call the drive shaft that really structural support to the body, because there is a very thin wire that goes inside that coil. But this is what provides you with the structural integrity and the support and strength to be able to push the burrs through tight lesion, and the burr itself, which is essentially a stainless steel component, spindle-shaped, and is coated with diamond. And the diamonds come in, they're specks of diamond or diamond sand, and they coat only the distal 40% or 1/2 of the burr itself. They come in different sizes. So they start at 1.25, but you get up to 2.5 millimeter burrs. And we'll come in a second to what sizes that we actually use in daily practice. One important thing is the stage where we set up the device is ensuring that the shaft is well attached and well latched onto the advancer. And this is achieved by this interlocking mechanism. And simply there's an interlock here that goes and they snap together, and there's an external sleeve that you slide over it to secure the connection. Now the Rota wire is a purpose-built wire that is relatively different than the wires we're accustomed to. So the tip is 0.014, it's a stainless steel wire, but the body of the wire is 0.009. And this has important implications. Essentially, you can't really rotablate over your standard coronary wire. And this wire, because it is built to support the high speeds of spinning of the burr, it is not exactly your best torqueable wire. So you can encounter difficulties in tortuous anatomies. The wire itself may be ruined and may be fractured if you over-rotate it a lot. So in complex anatomies, we advise that you cross the lesion with the regular workhorse wire, advance a microcatheter, then advance your floppy wire or your rota wire instead of that, and remove the microcatheter, then start your ablation procedure. Now, they come in two different stiffness profiles. So there's the floppy wire and the extra support wire. And in the vast majority of instances, we will use the floppy wire because it comes with an important feature of reducing guide wire bias. And guide wire bias means that the wire will preferentially point rather than towards the center of the vessel. It will be biased towards the extreme or the eccentrically towards one side of the vessel, sparing the other. This obviously means that you will be preferentially ablating one side of the vessel rather than centrally. Now, in some occasions, we do upgrade for the extra support wire. And this is essentially limited to situations where you're unable to cross with the burr and you need more support, or when you really want to have sort of a very focal and selected eccentric ablation. And this can happen when you have a 180-degree arc that is limited to one side of the vessel, but is yet expected to hinder stent expansion. Important part when we're setting up the system is a pre-run insurance that everything is in order, and there is an acronym for that. We call it DRAW, and by DRAW we mean that the drip is running, and the drip consists of 500, it's a regular 500 cc saline bag, 5 milligrams of verapamil, 5 milligrams of GTN, 5,000 units of heparin. Obviously that can be the Rotaglide solution added to the 500 cc saline bag, but that is not routinely available, at least not in Egypt. Now, the second thing is while you're still with the burr on the wire, latched onto the wire before inserting it into the catheter, you want to ensure that the burr is indeed rotating and that the burr speed is set to the desired speed. And we do this rather than putting it on a cloth, make sure it is already inserted onto the wire. It is elevated or suspended in the air so it doesn't rotate and capture pieces of your cloth from the draping. And we put our foot on the pedal and ensure that the speed is set to where we want, and we'll come to that shortly. We also want to check that the advancer is working, so your knob, the black knob that you use to advance and retract the burr, is active and is working. And you want to make sure that the brake is active, and the brake is a simple black button near the distal end of the advancer. And as long as it's expelled outside, that means that the brake is active, because this is preventing the wire from rotating with the burr as you start ablating. Now, the indications are pretty straightforward. So this is what we think of, how we think of calcified cases. Whenever you encounter mild calcification, it's more or less routine PCI. With moderate calcification, that's a 90 to 180 degree arc. We consider a non-compliant balloon, perhaps upgraded to a cutting or scoring balloon, then decide regarding rota if you do not achieve sufficient expansion. With heavy calcification, we go with rota straight away. Obviously, imaging helps to a great extent. This is how calcium looks like on optical coherence tomography, and you see this is on the top right panel, you see this is an almost 270 degree arc, and you can see that the calcium looks as an hypoattenuated shadow with a clear demarcating line between the non-calcified and the calcified lesions. On the other hand, with IVUS, we're all pretty much familiar with how calcium looks on IVUS, but this is a near complete calcification, both intimal and perhaps a few layers of medial calcification as well. So OCT both really provide important information. OCT is really useful when it comes to being sensitive at detecting calcium, but IVUS fares quite well with that as well. Now, OCT perhaps also is able to give you an idea about the depth of the calcification arc itself, and that perhaps can be useful for your initial strategy, because if it's a very thin line of calcification or thin sheet of calcification, even if it extends to a wider arc, there are pretty good chances of being able to overcome it with a non-compliant or a super non-compliant balloon. Now, we also use rota, whenever we're unable to dilate despite initial measures. And this is more likely to be encountered in CTOs whenever you are able to cross the lesion, but you're unable to deliver a balloon, then rota will become extremely helpful. One important thing is rota ablation is obviously not your modality of choice or best tool to use whenever you're encountering deep calcification. This is very much limited to the intimal side of the vessel. And if the main problem is a lot of medial calcification, then rotational atherectomy will simply not work. The technique, well, there are different stages to the procedure. You want to be able to start with selecting your guide catheter, then make a choice regarding the floppy or the extra stiff guide wire or rota wire, then choose the appropriate burr size. And with guide catheter selection, there are a number of issues that you need to be aware of. One is you want good coaxial alignment. You don't want to have a guide with more than one curve. So using an Amplatz left 1, for instance, is not your best choice, because this double curve at the end will inevitably lead to a degree of wire bias in the proximal segment of the coronaries. You also want the appropriate size, and I'll show you a chart for that in a second. And the presence of side holes is optional and really doesn't make a big difference whenever rota is in question. So this is the guide sizing chart, and two things to keep in mind. You can safely go with a 6 French guiding catheter as long as you're sticking to a 1.5 millimeter burr, but whenever you're going to a 1.75 burr, you need a 7 French catheter and an 8 French guiding catheter if you're using a 2.0 burr. In all honesty, I have not used any burrs bigger than 2.0 and we only do 2.0. So you're most likely going to be using your 1.5 burrs in 70% of cases. In 10% of cases, you'll use the 1.25, and in a similar percent, you'll use the 1.75 burrs. And this is just a diagram to show you what we mean by wire bias. So remember, the position, not only is the position of the guiding catheter going to influence how your wire sits across the coronary bed, but also the presence of the wire in the distal vasculature, how deep it is, whether there are multiple curves distal to the site of where you want to ablate, or which branch you choose to place the tip of the wire in while you're working. And this is why we hate tortuosity. So this is an example of you're ablating in this part, in the middle part of the vessel, and you have those two bends, and you can see how the wire chooses to sit with a lot of wire bias, obviously rendering your ablation inefficient, incomplete, and slightly increasing the risk of perforation as you'll be preferentially ablating through one side of the vessel. And this is how we overcome it. Remember that the distal part is a floppy component of the wire, and the floppy component will sit elegantly across those curves without pushing the entire proximal segment of the wire towards one side. One important message here is we hardly ever advance the wire too much beyond the part where we want to ablate, and this particularly applies in tortuous anatomies. You obviously want sufficient length distally to provide you with good support. You want sufficient length distally to avoid getting the burr over this floppy component, otherwise you risk the fracturing the wire. But we don't want it too distal to induce unnecessary wire bias. And the technique is we usually start with the 1.5. We opt for the 1.25 if it's a very tight segment or the vessel is very small. It's a 2.0 vessel, for instance. And the optimal technique is essentially a pecking motion. One thing I want to draw your attention to is I've seen people doing a very hectic or erratic pecking motion. So we avoid this very erratic pecking motion. You want to establish some contact with the calcified portion of the tissue you want to ablate, albeit without applying too much forward pressure. So there's a forward pecking motion, and we leave that forward slight pressure in place for a couple of seconds, then retract the burst. So it's pecking, but do take your time. One important thing is the system provides you with a number of different feedbacks. So you get tactile feedback because you feel the resistance, but you also get auditory feedback because the burr, the spinning sound starts to get thicker. And more importantly, you have a burr speed that is displayed on the monitor in front of you. So whenever the burr speed starts to fall above 5,000 RPMs, so let's say you started at 160 and you're getting a burr speed of 152, 153, you know that there is too much friction and you better back off. You also want to make sure that you do not advance the burr and ablate and leave the burr distal to the lesion and take your foot off the pedal. So you keep your foot on the pedal, you advance, you start pecking, you start attacking the lesion, and then go back to your baseline, then you can remove your pedal. Otherwise, if you remove your foot from the pedal, you can risk having the burr entrapped either in the middle of the lesion or distal to the lesion. So the speeds that we advise at this stage, the European Society advises a speed of 135 to 180,000 rotations per minute. We tend to be slightly more conservative at 135 to 175, with the standard being 160,000 rotations per minute. We also advise shorter ablation times, and I keep it less than 20 seconds, and even less in instances where there is some hemodynamic compromise that you're seeing on the monitor. So the patient is starting to get slightly bradycardic, blood pressure is starting to fall. Then we keep those short ablation times very short. This can happen in very proximal LEDs, in distal left main lesions, and with dominant right coronary arteries. And again, you want to keep your eye on the monitor to pick up decelerations of above 5,000 RPMs and stop ablating. Now, one important thing before you start actually putting your foot on the pedal is ensuring that the blood pressure is good because of two things. One, remember that your drip contains GTN, so you're continuously vasodilating and losing pressure. The ablation process itself, if associated with a degree of hemodynamic compromise, can cause further drop in blood pressure. And if you end up with one of the dreaded complications, there is no reflow, all your solutions might in fact, or a pretty good deal of your solutions might in fact lead to further drop in pressure. So we never start ablating if your systolic blood pressure is less than 100, and preferably we start getting blood pressure in a preventive way above 120 before the ablation. And perhaps the best way of doing this is phenylephrine being a pure alpha agonist. Now, why do we get this hemodynamic compromise with ablation, particularly with high burst speeds? Essentially because of trauma. So there's a lot of heat that is generated, there's microcavitation, there's particulate debris that block the distal microcirculation, and there's platelet activation that leads to platelet clumping and thrombosis, and you destroy RBCs with release of adenosine, which is the reason for bradycardia in frequent occasions. So this traumatic process is highly related to both the burst, or three factors: the burst speed, the size of the burr, and the length of the ablation process. And this is why we just stop. We don't go for unnecessarily high speeds. We don't go for longer periods. We give the vessel or the microcirculation a chance to breathe, and we electively select to go for smaller burr sizes than what we used to do in the past. And this is essentially is caused by a difference in the strategy or the philosophy behind rotablation. So in the early days, we used to consider it a decalcification tool. Then we said this is a debulking tool. Then we understood we're only trying to modify the plaque, and that is essentially create weaker parts within the continuous sheet of calcium, and this weaker part can be later on cracked by your balloon dilatation. Now, to overcome the trauma and essentially to diffuse the heat, we use a lubricant, and the lubricant can be the Rotaglide solution. This is not routinely available in Egypt, and the Rotaglide solution has a number of factors besides a number of chemical compounds, besides what we add in terms of GTN and verapamil and heparin, but that essentially also has a degree of antithrombotic effect, but it also is very efficient at reducing temperature compared to saline. In all honesty, saline is being used worldwide, and as long as you ensure that the drip is running for very long procedures, you want to make sure that you don't lose pressure in the bag, and we start off with a pressure of the bag with at least 200 millimeters of mercury. So this is the strategy or the philosophy behind contemporary rotablation use. It's plaque modification. And there are certain contraindications, or what we used to say as contraindications, although the vast majority of those are not absolute contraindications as such. So last remaining vessel, obviously you don't want to meddle around with that. However, in the presence of mechanical support, that can become a possibility. Severe left ventricular dysfunction, for the very same reason. If you get into trouble in the vessel, in the target vessel, you will end up with a collapsing patient. So again, consider mechanical circulatory support. We do not rotablate through saphenous venous grafts for obvious reasons. The presence of a thrombus is a contraindication and is still a contraindication. However, it is not very uncommon to use rotational atherectomy in non-STEMI patients in the culprit vessels. Now, obviously, those are older patients, and some of them have highly calcific and difficult anatomies that require rotational atherectomy to be able to treat. Significant dissection at the treatment site, again, is not an absolute contraindication, but it would really draw your attention towards being extremely cautious at what you want to achieve. So these are a couple of examples before we move to the troubleshooting and complication side. This is a 79-year-old male patient, hypertensive dyslipidemic ex-smoker, a severe COPD, angina on mild exertion, and presented with a non-ST segment acute coronary syndrome 8 months prior to this presentation. You can see the diagnostic angiogram of a circumflex lesion. There's a distal left main 50 to 60% lesion, and there's diffuse proximal LED disease. Perhaps this is more clear on the spider view. And what we see here is the ostium of the circumflex itself seems to be preserved, so we chose to treat this as a non-true bifurcation lesion, where you can see how bad the LED looks like. You also can see that the right coronary artery is filling retrogradely, and we'll show you the right coronary artery again, a totally occluded vessel, a relatively short segment of occlusion, but with high calcification or dense calcification all through the proximal one half of it. And this is where you want to have a clear strategy. So obviously, first we discussed this within our heart team meeting, and his syntax score, while 42, because of the comorbidities, the treatment recommendation, was still PCI. And to do this, we usually opt to stage such complex procedures. So we started off with the left system, and the plan was to do a focal circumflex stenting without getting into the bifurcation, rotablate through the LED, stent left main into LED, and use imaging for optimization, and then do the right coronary artery CTO in a second session. And this is one important message here is, whenever you encounter this degree of calcification, we really know it's not going to be dilated with balloons. So this is the sort of scenario we're going from the outset with. Rotational atherectomy saves time, saves undue complications or silly scenarios which can really get you and the patient into trouble. So we can start balloon dilating the proximal LED, end up with a lot of dissections, have difficulties in delivering stents, and you suddenly take a relatively elective and stable patient into this. So the message here is, whenever you think that this is not going to be amenable by straightforward conventional angioplasty, go with rotational atherectomy from the outset, using one non-compliant balloon, then the second, then the third, a cutting balloon, then a wire beside the cutting balloon, or a scoring balloon, then realizing 6 or 7 balloons down the line and half an hour down the line with a lot of contrast, that you still haven't really created enough expansion or overcome the calcification. Then think about rotational atherectomy with an unstable patient or with a lot of dissections is not really the best way to handle those patients. So we started off by stenting the circumflex, proximal circumflex, 140 stent, then rotablated with, because of the very small size of the LED, and one ratio we keep in mind as an upper limit is 0.6. So the burr size to the vessel size should not exceed 0.6. And so we started off with a 1.25 balloon, but you can see that there's still a waste in the balloon with a 1.25 burr, but there's still a waste in a 2.0 non-compliant balloon. So then we upgraded this to a 1.5 burr. We upgraded this to a 1.5 burr, and you can see that the resistance encountered in the first couple of runs, once you're able to overcome it, we do 4 or 5 to and fro runs, what we call polish runs with the burr, ensuring that during those polish runs, there is no drop or deceleration with the burr speed whatsoever. And this was an OCT just to understand our sizing, and we can run through that. This is after 2 stents, 2.5 stent distally and 3.5 stent proximally, which was optimized proximally in the left main with a 5.0 balloon. And that's the final result. And you can appreciate that the ostium of the circumflex looks still quite healthy. And one important thing, just to show you how Rota really is effective in such scenarios, is understand the full expansion of the degree of stent expansion after stenting. And you can see that the minimal stent area in the left main and the shaft is 18.3 millimeters. In the proximal, or in the polygon of confluence, is 18 millimeters, and in the proximal LED is 14 millimeters, and these are really the targets that we aim for. 1 week later, that was a relatively simple CTO, antegrade wireless escalation with a fielder XT, and again, that went relatively smooth. But again, after a 1.5 burr, delivery and stent expansion easily, and we ended up having to stent all the way into pre-bifurcation with 3 drug-eluting stents. So the second case is an 83-year-old gentleman, chronic kidney disease, shortness of breath and angina on mild exertion. He still leads an active lifestyle with severe aortic stenosis with an estimated aortic valve area of 0.7 centimeters squared, preserved left ventricular ejection fraction, and mitral annular calcification with mild MR. And again, you can appreciate the degree of calcification within his coronaries. very tight lesion in his proximal circumflex. You can also see a proximal LED disease without a clear landing zone prior to the left main. The right coronary artery is totally occluded. And you can appreciate from the epicranial view on the left-hand side that the right coronary artery is a very, very, very diffusely diseased vessel. So on this occasion, we thought about the double jeopardy of the aortic stenosis and the burden of coronary disease, and decided that if we're able to fix the left system and fix his aortic stenosis, that should get him off the hook. And this is exactly what we plan to do. Now, rotablating in the presence of severe aortic stenosis with a lot of left ventricular hypertrophy, high end diastolic pressure, can be a risky maneuver. So you really want to be quick. You want to be, don't overdo it with the burr size, because the incidence of no reflow can rise dramatically with the degree of microvascular dysfunction that is frequently present in those patients. So we opted for a simple T stenting technique. We started off, we wanted to protect the circumflex first. So we started off by rotablating the LED using the 1.5 Burr, put a stent in the circumflex, then put another stent in the LED, finished by kissing balloons and proximal optimization for the left part. And this was the final result after a lot of ballooning. But again, you can see that despite of the degree of calcification, rotablating was quite efficient at ensuring very good stent expansion in the proximal segment of the LED. Now, 1 week later, in terms of ischemia, the TAVI procedure was a very smooth one, now having been revascularized. And while we don't have strong evidence that one should precede the other, so we don't have evidence to support whether going for the TAVI first or the ablation or the coronary work first. In such situations where there's a huge burden of ischemia, we think that starting off with the coronary procedure makes a lot of sense, especially if it were a complex one, because you really don't want to be having all these maneuvers with a stent frame blocking the entry into your coronary arteries. And this is from a consensus document from a number of expert operators around the world. And it's just a brief reminder for the key steps of the procedure. So in terms of guide catheter selection, the guide wire selection, burr selection, and again, the emphasis is usually on a small burr of 1.25 to 1.5. Do respect that ratio of 0.6. And remember that the concept here is not really debulking as much as plaque modification, which can effectively occur with small burrs. You want to consider pacing. We hardly ever do it, in all honesty, except in either dominant right coronary arteries and dominant circumflexes, where we expect this to be a lengthy ablation procedure. And in those situations, we usually put in a venous sheath and leave the pacing sort of dependent on how the patient behaves, because you can always anticipate this with the slightest initial sign of bradycardia, stop pacing, and they usually resolve. And again, the recommended ablation and the burring technique and the rota flush, when to stop, and so sort of everything we've discussed summarized in one slide. Now, one thing you cannot ignore with rotational atherectomy is complications. Luckily, they're rare, but they do happen. Perhaps the most slow flow or the no reflow phenomenon. Perforation is a dreaded complication. Burr entrapment is another dreaded complication, and system malfunction, which is quite rare in all honesty. And this is from a meta-analysis of trials on rotational atherectomy. You can see that the incidence of death varies from none up to 4%. Perhaps those were the relatively older days with more aggressive techniques, but importantly, urgent CABG is less than 0.1%, and this is only reported in one study, with the others being 0. Now, perforation with the current sizing strategy that we use, we're not encountering those except in less than 2% of cases and 1% in our series. Now, the slow flow or no reflow phenomenon has a number of mechanisms essentially related to platelet activation and clumping, distal embolization, but other factors can be at play, including spasm, flow limiting dissections. And similar to what we encounter with acute coronary syndromes, prevention is really the key. We do not have definitive therapy for no reflow. And to be able to prevent this, you want to be short on your runs. 20 seconds is what we recommend, or even slower in patients that already have a degree of compromise in terms of hemodynamics, or have severe left ventricular hypertrophy, or you're ablating in a critical area like the distal left main or a superdominant right coronary artery in the presence of a diseased left system. Now, small burr size, avoiding high speeds, and ensuring that your drip is running at high pressure is the way to prevent this. Should you be unlucky and encounter it, you want to stop ablating, give the vessel time to breathe. You want to rule out dissection as the cause for the no reflow or slow reflow. You want to check ACT, intracoronary GTN, intracoronary adenosine, intracoronary verapamil, and nitroprusside may work in different degrees of success and in different combinations. And we usually opt to deliver this distally into the close to the microvascular bed via microcatheter. Now, perforations, you've all been aware now with the issue of wire bias that can be caused by tortuosity. So please be aware of that and do prevent it by adjusting the position or coaxiality of the guiding catheter and avoiding having the tip of the wire unnecessarily too distal in the target coronary vessel. Also, about deciding to ablate through extremely tortuous coronaries. And remember that guiding catheter with single curves will make the mechanics of the whole process much easier. And one thing that we don't really respect all the time is avoiding ablation into the subintimal space, although we infrequently utilize that when we're using CTOs, but that is mostly related to ablating the entry side into the subintimal space and the exit side, rather than ablating into the subintimal space itself, as the latter is usually very much able to accommodate stent expansion, albeit with slightly increased risk of vessel rupture. Now, this is just an example of some complication. This is a 71-year-old female diabetic with unstable angina. You can appreciate a very impaired left ventricular systolic function. And there was a CMR study that shows that the circumflex territory is also non-viable. And this is her coronary anatomy, distal left main disease, a heavily calcified proximal occlusion. The circumflex doesn't seem too diseased in all honesty, and the right coronary artery, which you can see on the right-hand side with a long lesion, again with a lot of calcification in its mid-segment. And we started off fixing the right coronary artery on this occasion to be able to provide her with some hemodynamic support during the left side, the left coronary system PCI. As expected, a lot of balloon dilatations initially, they did not work. We were relatively reluctant to start with rotablating in view of her severely impaired ventricular function, and that was at the time where we did not have any mechanical support beyond the intra-aortic balloon pumps. And we initially tried to dilate with super non-compliant balloons, with very high pressure balloons. And we thought we achieved good expansion, but then tried to deliver a drug-eluting stent that didn't work, got a guideliner, and tried to deliver a stent that again did not work. And effectively, we were left in a situation where we believed that we really have to rotablate. So this was a 1.5 Burr, and you can see that because of the repeated balloon dilatation attempts, there is a dissection flap that is extended proximally all the way into the distal left main and is also involving the ostium of the circumflex at this occasion. And that was the ablation procedure. Then we were able to deliver 2 stents smoothly, a distal 2.5 stent and a proximal 3.0 stent. And then while we were expanding the last stent that's left main into LED, you have this horrendous perforation. And obviously the patient collapsed immediately after this shot, pericardiocentesis immediately. An intra-aortic balloon was in place from the outset of the procedure. and we blocked the perforation site or the leak site with the balloon. You can also appreciate now, because of the combination of cardiac arrest and the dissection flap, there is no flow into the circumflex. So hemodynamics are obviously not the best at the moment. And we took the wire that was in the circumflex and put it side by side in the other wire in the LED. And over the second wire, we were able to deliver one of the newer covered stents. That's the B Brown stent. That's a single layer of PTFE, so it's low profile. It can be delivered next to a balloon within a 6 French guiding catheter. And then we were able to place this sparing the ostium of the circumflex. Then we were able to advance another wire into the circumflex. And while we initially had data related to viability, mentioning that the vast majority of the circumflex territory was non-viable, after circulation, the mitral regurgitation, which initially was mild to moderate, was severe at this point. So we thought we might as well stent the circumflex, which is what we exactly did. And this is something just to remind you of how we handle coronary perforations, be it with rotas or otherwise. And this is related to large vessel perforation. So you immediately want to block the site of perforation with the balloon. You want to prepare for blood products. You want to give IV fluids and pressors if there's hemodynamic compromise. Pericardiocentesis is obvious if the patient is tamponading. If the bleeding is significant and you are short of blood products, you can consider autotransfusion. And we do this by connecting the pigtail from the pericardial sac into one of the blood bank collecting bags. So those are already treated with EDITA, and the risks of clotting and retransfusing clotted blood are significantly tempered. Now, you also want to notify surgeon just in case your interventional toolkit is not sufficient. One important thing I want to draw your attention to is we do not give protonin except after the procedure has ended. Otherwise, you end up with double jeopardy, which is a bit of bleeding on the one hand and thrombosis because you still have intracoronary gear in place. And the other thing I want to draw your attention to is, regardless of whether you left a balloon pump in, an intra-aortic balloon in, or you're giving heparin for whatever reason, we do not give heparin for the first 6 hours after the procedure because that can lead to rebleeding. And obviously those patients can rebleed, so they stay overnight. Those are not same day discharge by any means. Those, because this was essentially related to the older days when we did not have any covered stents apart from the stent graft from the graft master, which was 2 layers of metal with a PTFE layer in between. So those were essentially impossible to deliver through the same system. You had to establish another vascular access and another system and use a ping pong technique to be able to block and deliver via two different systems. Now, this is the same patient 4 hours after the procedure. Now, we left the pigtail in. She was doing fine. Then her blood pressure started to deteriorate. We took her back to the cath lab, and you can see that there's still perforation at the very same site. And the reasons for this is, and this was fixed with extensive balloon dilatation. The reason for this is, with those PTFE, they tend to recoil, and the recoil is in the range of 5 to 6%. So the initial results you get can be lost a few hours down the line because of the recoil you encounter. So what we usually do is choose a covered stent that is 2.5 or 0.25 millimeters larger than the stent that we used or the expected vessel diameter. And do use high pressure post dilatation to make sure that this is well expanded. There's also another reason for such phenomenon in patients that you put a covered stent after cardiac arrest is the intense coronary vasoconstriction. So with a lot of vasoconstriction that happens in the aftermath of an arrest, you tend to underestimate the true size of the vessel. So there's 2 components why you can really end up with this sort of bleeding. And obviously, if you're using heparin for whatever reason, it will increase the chances. Now, perhaps the final the final complication that you can encounter is Burr entrapment. And there are really 2 mechanisms by which this can occur. One is having a small burr Now, the 1.25 Burr is slightly different in terms of its shape to the rest of the family. The 1.25 Burr has a bullet shape. And by bullet shape, it means it doesn't have those shoulders that come with a spindle shape with the other Burr sizes. And that makes it particularly prone to what we call a kokesi phenomenon, which is the Japanese doll here. And that means that if you push too hard or with a high speed, and the distal part of the Burr is able to slide through the lesion, taking it back might prove to be difficult because the widest component of the Burr is actually its base, and this is the base of the bullet. So it can really jump in, and on the way back, you will encounter resistance and the Burr becomes entrapped. The other is the more logic type of entrapment, is getting a large Burr entrapped in a long or an angulated calcified lesion, and this is what we call deceleration entrapment. And you usually get signs for this is gradual deceleration, then it stops. So attention is, do remember that the 1.25 Burr can be tricky. Avoid vigorous pushing. Always use the repeated pecking motion with only minimal forward pressure. Never stop in the middle or distal to the lesion. You want to be cautious with tortuous or angulated segments of the vessel, and you want to keep an eye for significant deceleration while ablating. And if you do encounter the complication, you want to remove any spasm. You want to try to pull back manually, but obviously you want to keep an eye on your guiding catheter to avoid deep engagement and proximal vessel injury, which can be fatal. And you don't want to push too hard to the extent of fracturing the shaft. If this doesn't work, you can try delivering another wire next to the Burr. Now, this is frequently not something easy to do. Remember, those are highly calcified and tight lesions. So we frequently have to use very stiff and tapered wires. So a classic wire for such scenario is a CP12 or a Hornet 14. And you want to get this through a second guiding catheter, perhaps, which is easier because you won't have a lot of space in your initial guiding catheter. If you don't have another vascular access or you don't want to do it, you can cut the drive shaft close to where it connects to the advancer, remove the plastic sleeve, and then you will have a lot of space to work with inside your initial guiding catheter. Now, once you're able to deliver a wire next to the Burr, you can get a small balloon and do gentle repeated inflations to try and free the Burr. And this is how we cut the shaft, and this is the sleeve. I'm not sure if it's clear where you are, that has been ripped off the stainless steel central core. Now, perhaps one important thing is using a guide liner, and this is my favorite initial maneuver, because using a guide liner, again, to be able to deliver the guide liner, you cut the shaft, remove the plastic sleeve, drive the guide liner over the stainless steel central cord, and you start pulling back. But here you're pulling back with two main differences. One, the guide liner is all the way into distal into the vessel and is engulfing the Burr. So it's creating sort of what we do with removal of pacemaker leads that have been there for a long time. So you establish a very firm circular entry port through the guide liner for your Burr to go through. And this is establishing a cleavage plane around the Burr or between the Burr and the vessel wall. You also are able to improve the coaxiality of your pulling force. So rather than pulling and this pulling being dissipated across a lot of curves, you're now delivering more coaxial and more effective pulling force at the level of the Burr, which is really where you want to apply your force. And this is the, obviously, in case this does not work, surgical removal becomes the last option, although this is not an easy solution by any means. This is obviously an emergency surgery, which comes with its own risk, but also from a surgical point of view, freeing a Burr in the middle portion of the LED is not exactly the easiest way. They will have to open it and graft the vessel. So it's not really a procedure that you want to end up with, although it is a last resort. And this is an algorithm that just sort of depicts what we've just said. So to wrap it all up, now you have you do an angiogram, you have mild calcification, this is no atherectomy. Moderate calcification, you're in doubt, imaging is probably the best thing to do from the outset, because that can point you towards rotational atherectomy or orbital atherectomy from the outset, or towards a balloon if you get more favorable patterns of calcification. Now, even with mild calcification, if you're unable to achieve good balloon dilatation, you can shift towards rotational atherectomy. But one important message here is when you start off with severe calcification, rotational atherectomy from the outset is probably both more effective and safer, including cost efficiency, by the way. It's using multiple balloons, cutting balloon and a scoring balloon, and a guideline to be able to deliver stent obviously costs money as well. Now, a couple of miscellaneous points that I want to draw your attention to is there is a lot of force that can happen when you're advancing the rota, the Burr, essentially at the site of the primary curve of the guiding catheter. Now, this can cause the proximal part of the wire to loop, and because this is an 0.09 wire, it can be missed. And this leads to a problem because once you advance the Burr outside the guiding catheter, you lose the whole system. So be sure that you don't have this sort of loop in the root of the aorta. Now, the last thing that you can encounter is you've done everything right, but the Burr isn't advancing. And this is where you have to deploy a sequence. And the first thing is do apply more gentle forward pressure. Perhaps rather than more forward pressure is longer contact time, but obviously with keeping an eye on deceleration and hemodynamics. A smaller Burr can be extremely effective. In rare occasions, when we have this very tight focal lesion where we're unable to advance the Burr, we can take the Burr up to 180, 185, and occasionally, which is very rare in all honesty, to 190,000 RPM. Consider the extra support wire. And if this is all not working, you might want to consider alternative maneuvers, and these are essentially CTO maneuvers for uncrossable lesions. So a granuloplasty, laser can be extremely helpful, but obviously is not available, is not really an option in Egypt. But you can use granuloplasty, which can be effective. You can use another wire and try to dilate it. You can use a blimp balloon, or you can choose to go subintimal and re-enter distally, and this will you're going around the calcium rather than through the calcium essentially. And this is relatively old. That was back in 2015, but for further reading, this is an excellent piece. It's a European expert consensus document in Euro intervention back in 2015, and it really summarizes all the key messages in this brief lecture. And one good thing is, and Ahmed Khashaba is one of the authors on this paper, which is something يعني كلنا سعداء. Thank you very much.
Thank you, Ahmed. Actually, you covered the subject as nobody did before. You covered all the aspects of rotational atherectomy. You discussed calcification and the impact of calcification on the procedure success. You discussed the indication of rotational atherectomy, the technique, the tips and tricks, the complication, and how to manage. Thank you very much, Professor Ahmed. Let me ask you, are you aware of the routine use of rotational atherectomy and its effect on long-term events? I mean, I know that we have a procedure success, better gain, but what about the long-term events? Can this be reduced with routine use of rotational atherectomy?
Thank you, Dr. Mohammed. That's an excellent question. Now, you might remember that in the older days, one sort of hope with rotational atherectomy was in-stent restenosis. Now we have solid data to support that it doesn't really work with in-stent restenosis. It's just attacking sort of a different pathophysiology altogether. So you do end up with initial gains in terms of lumen area, but on the long term, the clinical outcomes were similar, if not worse, with more aggressive in-stent restenosis tending to recur. Now, we don't have this sort of randomization between patients who have done rotational atherectomy facilitated PCI versus those who have not, and comparing their major adverse outcomes down the line. But we do have very strong surrogate measures that tell us that the degree of stent expansion achieved with rotational atherectomy is substantially better. And we do have a lot of data to support that the degree of stent expansion is strongly related to further major adverse cardiovascular events down the line, including the need for reintervention and cardiac death.
Okay. If we have severe calcification on angiography, would you like to start with a cutting balloon, scoring balloon, or would you go immediately for rotational atherectomy? What is your policy?
So it really depends. هنا بقى هنتكلم on the practical side. If you happen to be in a place where rotational atherectomy is available, I would go for rotational atherectomy straight away. Now, if you happen to be in a place where rotational atherectomy is not available, you have two options. One is to avoid ad hoc PCI because you do not have any sort of assurance that your cutting balloons and regular balloons are going to work. Two is try to proceed and see what happens. But obviously it becomes a gamble without having a good plan B. But with severe calcification, my strategy, and this has come from sort of bad experience, as well as obviously listening to a lot of colleagues around the world, is it makes perfect sense to start with rotational atherectomy from the outset. It saves you, and more importantly, the patient, problems related to being unable to establish good flow with balloons. And I remember we had one patient, although obviously this is far from being evidence, but this is personal experience with the father of a colleague, where we were working in a place, looked like a dry coronary artery, wasn't really calcified, and but he was quite old, he was 87 years old, but it turns out to be quite fibrotic. Did a couple of balloon dilatations. We were able to get a 1.2 balloon into the RCA with difficulty, and started dilating, dissection, unable to upgrade the balloon size, unable to deliver anything, and no reflow in the right coronary artery, hemodynamic collapse, put him on a balloon, intubated, and the only way we could fix this mess was getting a rotablator ad hoc in the middle of a procedure in an emergency, and he was on huge doses of noradrenaline and adrenaline. Now obviously at 87 he went into kidney failure, and did not make it out of hospital. So this was the type of vessel where having rotational atherectomy on site and doing it early on would avoid you a lot of complications down the line.
Ahmed, one last question. I think nowadays there is no rule for routine glycoprotein 2B3A or routine pacemaker, temporary pacemaker. There is not routine anymore. No,
there is no. We hardly ever 2B3A in rota patients in particular, and routine pacing is far from what anyone does really. When we're conservative, we tend to put in a venous sheath and leave it standby just in case we need backup pacing. And in all honesty, for the past 3 years, we've only used pacing in 2 procedures.
Okay. Now, Professor Yasser Baghdadi, if you have any questions or any of our colleagues, Dr. Karim Mahmoud.
شكرا يا أحمد. أنا ما فيش سؤال حقيقي بصراحة، أنت خطيت الموضوع كويس قوي. أنا بدور على كريم بس عشان هو كان عايز يسألك سؤال، فلو تستنى معي دقيقة واحدة بس. مش لاقي كريم. وهسألك السؤال اللي هو كان بيسأله. هو كان بيقول هل is there a role do we have to use imaging routinely? Is it mandatory ولا بس أنا بتاني وريت سلايد بكده بس يعني برضك إذا تحب تجاوب. Is it mandatory to use imaging when you use root ablation ولا لا؟
والله يا دكتور ياسر موضوع الإيميجينج is probably one of the highly underutilized sort of adjunctive tools in the cath lab. Now let me start by calcification on the angio. So this classic railroad sign, two orthogonal views, essentially means if you're seeing it in one view with two planes of calcium, معناها إن you have two opposing calcium sheets, and if you see it in an orthogonal view, and again you end up with the same railroad sign, that means you have a 360 arc. This is obviously far from being sensitive or accurate, doesn't provide you with the density of calcification, the completeness of arc, the thickness of the calcium sheet. كل دي حاجات ممكن تيجي من الإيميجينج. There is strong data, albeit mostly retrospective, but retrospective from a 10,000 patient registry. Now, the use of imaging in complex interventions, and in this study, this was from South Korea, complex interventions can at any stenting more than 40 millimeters in length, calcified lesions, chronic total occlusions, and true bifurcation left main disease. في الcohort ده كله, the use of intravascular imaging was associated with significantly less major adverse cardiovascular event, including myocardial infarction, cardiac death, and or mortality over a 5-year follow-up period. I would not say no imaging is mandatory for rotational atherectomy from a technical perspective, but I honestly believe that if you want to end up with a good outcome in patients with such degree of complexity, you would require imaging for more information and ultimately for stent optimization at the end.
Please, if any one of you would like to ask Professor Ahmed ElGuindy, I'm sure that all of you know how to use the hand sign, just press reaction and hand sign. We're waiting for questions from you. Professor Ahmed, do you have a special tips and tricks after we finishing the atherectomy procedure? Of course, we should exchange the guide wire. Then we should use a balloon, a non-compliant balloon, or direct stenting, stent 1-to-1. Do you have special protocol or tips and tricks after we finish rotational atherectomy?
Again, excellent question, Dr. Mohammed. Now there are a couple. Getting the system out and completing your procedure is again an important topic. One is you want to be able to remove the burr, and to be able to remove the burr, you unbrake the system. So the brake, the black button at the end of the advancer, you push it. So this releases the brake on the wire. Then you use Dynaglide, and Dynaglide is a mode on your foot pedal that allows the burr to spin at 50 to 90,000 RPM without a safety mechanism. So it doesn't stop if it runs into deceleration. And we do it on the way out to facilitate removal. Now, if you were cautious with your initial manipulation of the wire and you don't have any bends, the mere speed and the saline flush will allow you to remove the system without even compensating for the wire. فتقدر تسحبه similar to how we flush a microcatheter, for instance. And if that doesn't work, you have to do it manually. It's a 330 centimeter wire, so it can be relatively irritating. But anyway, once you've done that, what I've learned to do is advance another wire next to the rota wire. And through this wire, if you don't have many dissection planes, which is hardly ever the case, advance another wire, and over this wire, start doing your ballooning. And when you do your ballooning, we don't go a lot over the nominal size of the non-compliant balloon. So if it's 12 the nominal pressure, if it's 12 atmosphere, we go 14, 15, but we don't do the 20s and 26 and 28s and so forth. Because with ablation, you're inevitably bound to have relatively weaker parts of the vessel, so you don't want to cause injury there. And if you get good balloon dilatation, The presence of a rota wire will facilitate two things. One, it can act as a cutting wire per se, next to the balloon. And two, you will still have it in place should you realize that you need to upgrade the burr and do further ablations. فالبالونة did the job. We're happy. We removed the rota wire and start stenting. The balloon is still under expanded. We still have the rota wire in place, so we save time of having to reintroduce it. And similar to the non-compliant balloon, with the drug-eluting stent, we go nominal, slightly above nominal, but again, we don't go for the 20 and 22 because you essentially don't need it had you done proper preparation.
Thank you, Professor Ahmed ElGuindy. Actually, we enjoyed your presentation very much. We're looking forward to see you again and again in our webinars. You have expertise in different fields of interventional cardiology, and we are looking forward to hear a lot from you, inshallah, in the near future. Thank you, Professor Ahmed ElGuindy. Thank you, Professor Yasser Bondadi. Thank you, all my colleagues. See you soon, inshallah.
تصبحوا على خير. Thank you, Dr. Yasser. Thank you, Dr. Mohammed. Thank you, everyone. تصبحوا على خير.
كلكم طيبين. السلام عليكم.
مع السلامة.
شكرا جزيلا. كل سنة وانتم طيبين.
حضرتك طيب.
شكرا.